Hi, my name is Meghan Romba, and I'm an acting assistant professor in the Department of Neurology at University of Washington and also an MS neurologist at the UW MS Center. So today I'm going to be talking about MOG-Antibody disease as well as NMO spectrum disease and giving an update on both of the conditions. We'll start by talking about anti-MOG disease, specifically the demographics, clinical presentation, MRI findings, the clinical course and prognosis, and how that differs from MS, and then the treatment for both the acute and relapsing acute setting, and then also the relapsing form of the disease. And then we'll start talking about NMOSD afterwards regarding demographics of the disease, clinical features, MRI findings, as well as the diagnostic criteria that are used, how we treat acute relapses, and then the preventative treatment landscape. So what is MOG? We know that MOG is a transmembrane protein that is present on oligodendrocytes and the outside surface of the myelin sheath. MOG stands for myelin oligodendrocyte glycoprotein, and it seems to be involved with maintaining microtubule stability as well as involvement in the complement cascade. So MOG antibody has been known for a few decades, and it was initially thought to be a biomarker of multiple sclerosis, but more recently in the last 10 or so years, we have found it to actually be a distinct neurologic entity separate from NMO or MS. MOG, we know, actually anti-MOG facilitates a complement-dependent cytotoxicity in vitro among EAE mouse models that is similar to an NMO-like presentation. And in 2007, there was a key study that was published by Kevin O'Connor, which I have here. And he described an assay that could detect antibodies to conformational MOG. And up until this point, all the older studies that were looking that basically were looking at denatured MOG. And his assay was able to differentiate these antibodies to MOG and found that these antibodies were rare in multiple sclerosis and common in ADEM-like presentations. So this prompted basically a improved assay for detecting conformational MOG, and it went on to develop a cell-based assay. And then most recently with Patrick Waters in the UK, there's been increased specificity based on using an IgG1 specific secondary antibody to targeting MOG. So anti-MOG, also known as MOG autoimmune encephalitis and MOG antibody disease, we think of it as an inflammatory demyelinating condition that can be either monophasic or relapsing. And the presentation and imaging do not meet your typical criteria for multiple sclerosis. And you have to have the presence of serum MOG antibodies that are detected using the cell-based assay, or the cell-based assay that we use is the one provided by Mayo Clinic. So anti-MOG or MOG antibody disease, the demographics. So this is a relatively new condition, and so we have pretty limited epidemiologic studies so far regarding the incidence and prevalence. I will highlight one study that was published in the last year that sheds a little bit more light on that. But we do know that it seems to have a slight female predominance. Any age can be impacted. The average age is around 30, early 30s. And we know that children and young adults can also be affected. It doesn't seem to have a race predominance, and the risk of relapse is estimated to be about almost 50% in the first 2 years. And just to back up, we'll talk about this a little bit later, but the risk of relapse seems to be tied to whether someone remains antibody positive or not for MOG. So this study comes out of Oxfordshire, the UK. And what they found was, so Oxfordshire is, I think about 650,000 people. And it seems that MOG antibody or MOG IgG was more common than aquaporin 4 IgG. It seemed, so the prevalence that they calculated was 20 per million with anti-MOG versus 12 per million with NM or aquaporin 4 disease. And the incidence was 3.4 per million for anti-MOG versus 2 per million for NMO. So the clinical features of anti-MOG definitely mirror NMO, but there are also some other things that are different, which we'll highlight here. So interestingly, patients who present with anti-MOG, they commonly have a preceding viral prodrome of fever, upper respiratory tract symptoms, or malaise. The most common symptom is optic neuritis. It can be unilateral or bilateral. This is then followed by transverse myelitis. And the difference here between NMO and MOG is that MOGs are more likely to have short segment myelitis, where NMO is characterized by the longitudinally extensive myelitis. ADEM and brainstem syndromes have been reported. And then another different feature from NMO is that patients with MOG can present with unilateral cortical lesions that are associated with seizures. This is a study this is the UK cohort that looked at 252 patients who were positive for anti-MOG. And they looked at the demographic and clinical data of those patients and found that patients who were under the age of 20 or less than 20 years of age, the most common presentation was ADEM. And patients with disease onset between 20 to 40 years of age most often presented with unilateral optic neuritis. And then patients who were over the age of 45 were more likely to present with bilateral optic neuritis and more likely to have short segment transverse myelitis rather than longitudinally extensive myelitis. And specifically talking about the optic neuritis that can happen with anti-MOG disease. So it's the most common symptom that occurs with anti-MOG disease, affecting slightly more than half of anti-MOG patients. It can be relapsing or monophasic, and it seems to have a lower risk of relapse than NMO regarding the optic neuritis. However, if patients do relapse with anti-MOG, they usually relapse with optic neuritis. And it does seem, fortunately, that patients who have optic neuritis secondary to anti-MOG have better visual outcomes long-term compared to NMO. So some other interesting features about the optic neuritis. So there's actually about 80% of patients will present with optic disc edema, and I'll show you a photo of that in a second, and it can be moderate to severe. Almost half of patients with anti-MOG will have bilateral optic neuritis. Like I mentioned, the recovery is better than with NMO spectrum disease, and it's pretty often that you'll have longitudinally extensive involvement of the optic nerve with MOG optic neuritis. You also can have optic nerve sheath enhancement with optic neuritis secondary to anti-MOG. And interestingly, you can have periorbital inflammation that can be associated with headache. And this is a picture here of the periorbital inflammation that is happening in conjunction with MOG optic neuritis. So I included this picture because I wanted to show you an example of bilateral optic neuritis. You can see bilateral optic nerve enhancement that's longitudinally extensive. And then also this red arrow on the left is pointing to the subtle optic disc edema that you can pick up here on the axial images. And then on the coronal images here on the right, you can see both optic nerve enhancement in the left optic nerve, and then you can see the optic nerve sheath enhancement on the right. So switching gears to the transverse myelitis that can happen with anti-MOG, it's typically more severe than the myelitis attacks we see in MS. It can actually mimic acute flaccid myelitis secondary to enterovirus, and it's rarely associated with longitudinally extensive myelitis, which is in contrast with NMO spectrum disease. And it's estimated that longitudinally extensive myelitis secondary to anti-MOG only happens in about 2% of cases. I definitely have seen it before, so if you are seeing someone with longitudinally extensive myelitis, you should be sending both MOG and aquaporin 4 antibody. Bowel and bladder disturbance are common with MOG myelitis and actually can persist after motor recovery from myelitis. So another interesting finding is something reported by the Mayo Clinic. And so on axial images, when a patient is presenting with anti-MOG myelitis, you can see something that in the gray matter that takes the shape of an H, and this is called the H sign. And this is something that is interesting and has been reported in 30% of patients who are presenting with myelitis secondary to anti-MOG. And it differs from NMO in that usually NMO involves both the white and the gray matter of the spinal cord. And also one other thing is that it differs from MS because MS usually causes lesions in the periphery of the spinal cord, whereas spinal cord lesions from NMO and MOG cause centrally located lesions on axial imaging. So talking a little bit more about additional imaging and findings that we see with anti-MOG disease. So the brain lesions can present in a variety of ways. So I put this table together to highlight some of the different changes that we see in the brain when a patient is presenting with anti-MOG. So you can have multifocal white matter changes, subcortical changes with anti-MOG. You can also see your typical ADEM fluffy white matter changes. And then also you can have imprintatorial lesions, but typically the imprintatorial lesions are more diffuse than in MS. And you can also have bilateral cerebellar peduncle lesions secondary to anti-MOG that is highlighted here. You shouldn't be seeing periventricular Dawson's fingers lesions. There is an overlap in MRI changes with aquaporin 4 disease. The difference though is that this isolated unilateral cortical change that you see with anti-MOG, you shouldn't be seeing. It hasn't been reported with aquaporin 4 disease. And then also, it is uncommon to have silent lesions outside of relapses with anti-MOG, whereas this is a common finding with MS. So this is a young, this patient, I highlighted this because this is someone who, a 5-year-old who presented with ADEM, dysarthria, altered mental status, ataxia, and her initial presentation is highlighted here in figure A and figure B. She was treated as ADEM and then had resolution of her symptoms after receiving steroids, and then presented 10 months later with resolution of her initial lesions, and then had new lesions that were popping up in the subcortical white matter with patchy enhancement involving the left parieto temporal region. She was diagnosed with recurrent ADEM and then sent to us for a second opinion. And she, in fact, actually turned out to have anti-MOG, and it was not tested the first time. But if you have a patient with ADEM, you should really be sending anti-MOG, and then definitely if they're presenting with recurrent ADEM, anti-MOG needs to be sent. So regarding recovery from anti-MOG, recovery is generally pretty good. So the UK cohort found that almost 80% of patients reported good or full recovery following an acute anti-MOG attack. It seems that younger patients have better recovery. And also, if you presented with unilateral optic neuritis or ADEM, you are more likely to make a full recovery. than if you had bilateral optic neuritis and transverse myelitis. Another point of something that I want to make sure that I mention, because this is different from NMO and MS, is that sphincter dysfunction can be permanent even though patients recover from motor symptoms with anti-MOG myelitis. So despite recovery from motor weakness from myelitis secondary to MOG, patients can be left with this permanent sphincter disturbance that can be a big problem for our young adults with anti-MOG. So this one study from the UK also highlighted that 28% of patients following motor recovery from myelitis, 28% of them had permanent bladder issues, 17% required long-term catheterization, 20% had bowel dysfunction, and 44% had erectile dysfunction in males. Regarding CSF findings, I haven't talked about that up until this point, and I just want to make sure that I mention that the majority of patients who have anti-MOG disease usually will not have bands in their spinal fluid. It is reported, but in less than 15% of cases. Patients who have anti-MOG disease, they can have a variable white count. I've seen normal white counts. I've seen white counts up to the 50 to 100 before. So it can be highly variable, but it is typically lymphocytic. And we do not send anti-MOG on the CSF, given that its role is uncertain, so it's not recommended to send. So the risk of relapse with anti-MOG, it seems to be related to whether someone is persistently positive persistently positive for MOG IgG over the next 6 to 12 months. And it also depends on whether they had optic neuritis at onset. So optic neuritis at onset was correlated with a higher risk of relapse and more likely to relapse as recurrent optic neuritis. So the relapses that happen with anti-MOG, 80% of them are optic neuritis. And I mentioned this a few slides ago, but silent MRI lesions are common during anti-MOG attacks. So for example, if you have a patient who's presenting with myelitis and you image their brain, you might find lesions in the brain. And it's common to observe additional asymptomatic lesions. It's estimated to occur about 20 to 50% of the time with relapses. Silent lesions independent of anti-MOG relapses are uncommon. And this is different from MS, as it's very typical to see silent lesions outside relapses and over time with MS. So how do we treat an acute anti-MOG attack? So anti-MOG is very steroid responsive. So we give IV methylprednisolone 1,000 milligrams once daily, typically for 5 days, followed by a prolonged prednisone taper. And it's not exactly agreed upon the duration of prednisone, and it really varies among providers. The UK group uses a minimum of 6 months and then retest the anti-MOG at that point. And if they are seronegative at that point, they will taper off the steroid. But the patient should be receiving at least 1 month of prednisone if they are indeed found to be anti-MOG positive. And that's the prednisone after they've received the methylprednisolone upfront. So this study is in further support of a prolonged prednisone taper. So in these patients, what they found is that if patients had received a prednisone taper for less than 3 months, they were at higher risk of relapse. And the risk of relapse was lower for those who had received extended prednisone for 3 months or longer. And those treated with prednisone for 3 to 6 months or longer than 6 months, their relapse, they relapsed at 22 to 25% versus 47 to 53% in those who were treated with prednisone for 3 months or less. So that's talking about the acute phase of anti-MOG. But for patients who are deemed to have a relapsing anti-MOG, it's a little bit trickier about what to do long-term for them, as there is no randomized clinical data available in treating relapsing anti-MOG disease. It appears that IVIG is helpful for children in both the acute setting and also as maintenance therapy long-term. Steroid-sparing agents that have been tried, there are many, azathioprine, mycophenolate, methotrexate, and Rituxan. So this one study published in 2019 showed that indeed, if you did use a steroid-sparing agent, that it did reduce the relapse, relapse rate compared to placebo. And this group used azathioprine, mycophenolate, and rituximab, and that seemed to reduce the risk of relapse compared to placebo. The group also looked at methotrexate, mitoxantrone, Cytoxan, and then our MS-DMTs. And did not find that there was a significant difference in reduction of relapse rate compared to the mycophenolate, Rituxan, and azathioprine. So I bring this up because as an MS doctor, we know that Rituxan is very useful in MS and very useful in, it's very effective for both MS and NMO spectrum disease. However, it's not exactly clear how effective rituximab is in the treatment of anti-MOG disease. So this paper compared rituximab and the response to rituximab between anti-MOG and aquaporin 4 disease. And what they found was in the patients who were seropositive for aquaporin 4, the risk of relapse over 38 months, so 24% relapsed over that period of time after Rituxan was started. And it was largely dependent on whether the B cells had repopulated or not. And this is in comparison to anti-MOG, where 38% of the patients relapsed at half the time period of NMO, and it was actually independent of B cell depletion. And this is important because it raises the likelihood of possibly other unknown immunologic mechanisms outside B cell depletion that could be driving anti-MOG disease. So for our relapsing patients, again, other things that have been tried, I mentioned briefly IVIG. In the literature, there's been over the last 4 years, 17 patients that have been reported as receiving IVIG for anti-MOG, and it seems that children just have a better response to it than adults. Adults were more likely to relapse on maintenance IVIG. And then tocilizumab has been used. There's a couple case reports of that, and it seems to reduce relapses as well. I've used it twice. And then, so the clinical course and prognosis. So clinical course seems to really be due to, or depends on whether or not someone stays antibody positive for MOG or not. And most permanent disability seems to arise from the initial episode. And in comparison to MS, there is no secondary progressive course that has been reported. So what we recommend is retesting the antibody anywhere from 3 to 6 months. 6 months seems to be kind of the agreed upon time with most MS providers. And this will just help us just determine whether that patient has a higher risk of relapsing or not. So in summary, MOG-IgG disease is a separate disease entity from MS and NMO. Optic neuritis is the most common presentation. And if you have optic neuritis at the onset, you have a higher risk of relapse longer term. Other clinical presentations, transverse myelitis, more common to have short segment than long segment with anti-MOG. Brainstem syndrome, ATEM-like presentation, seizures, and cortical involvement have all been reported. Relapse recovery is better than with aquaporin 4 disease, and permanent sphincter dysfunction can occur despite full motor recovery after myelitis. A few other things on the summary list. Long-term risk of relapse remains unknown, but it seems to be associated with whether someone has a persistent antibody for MOG or not. Silent MRI lesions outside relapse are not typical. And the treatment, acute setting, very steroid responsive. The long-term treatment remains unclear. And please keep in mind that these patients might not respond well to Rituxan, and IVIG may be effective in children. So switching gears to NMO spectrum update. So we know that, so NMO was previously known as Devic disease, and it was described in the late 1800s by Eugene Devic, and he actually, it was described after he saw on the autopsy someone with both optic neuritis and transverse myelitis. And eventually it was revised to NMOSD to highlight the clinical features of optic neuritis and transverse myelitis. It is a channelopathy, so it's an autoantibody against aquaporin 4. And it's rare in Caucasians, more common in Asians and African Americans. Median age of onset is 39 years of age. However, it can occur in pediatric onset as well. 80 to 90% have a relapsing course, and it carries a high risk of severe disability and mortality. So this is a timeline of NMO. And so the NMO criteria were first described by Wingerchuk at Mayo in 1999. And this helped sort out, and it helped sort it out and separate NMOSD from MS. And it highlighted the core clinical characteristics of longitudinally extensive transverse myelitis and severe optic neuritis. This was then followed by the discovery of the aquaporin 4 antibody by Dr. Lennon in 2004. And then the NMOSD term started to be used in 2007. And then most recently, there was an international panel that determined the diagnostic criteria for NMOSD. They left the core principles of optic neuritis and longitudinally extensive transverse myelitis, but they added additional supportive criteria that we'll go through in a little bit. So aquaporin 4 water channel. So it's located on the end feet of astrocytes, and you can see here in this Nature paper, it's these little red-orange dots here, and they're clustered around blood vessels. This yellow cross-section is cross-section through a blood vessel, and so it's outside the blood vessel, and its job is to maintain the integrity of the blood-brain barrier and help make the blood-brain barrier more efficient. So with NMOSD, what happens is that immune tolerance is broken. And so tolerance of the immune system is broken, and it leads to attacking of this aquaporin 4 water channel, secondary to an autoantibody. And this leads to deposition of antibody and complement and this profound inflammatory cascade that ultimately leads to depletion of the aquaporin 4 water channel, and you get extensive edema, injury, necrosis, and axonal injury, and ultimately permanent disability. So the clinical features of NMOSD, so optic neuritis and myelitis. Optic neuritis can be unilateral or bilateral, but the vision loss is much more severe with NMO than with MS or MOG. Myelitis can be severe, and it spans 3 or more vertebral segments in size, and you can also have painful dystonic muscle spasms with spinal cord lesions, and it occurs up to 40% of patients. Optic neuritis and acute transverse myelitis can occur simultaneously with NMOSD, and that occurs about 4% of the time. So I highlight 2 other things here. This is from Continuum, I believe, but this shows that you can have extension of the spinal cord lesions into the brainstem. It can actually be one of the first manifestations of the disease, and this can lead to neurogenic respiratory failure and potential death in NMO. And it occurs in about 20 to 30% of NMO patients. Another interesting thing, and this is part of the core clinical characteristics now of the diagnostic criteria, is area postrema syndrome. And so you can see here this lesion around the fourth ventricle, this T2 hyperintensity. On the sagittal and the axial. And this patient presented with intractable nausea, vomiting, and hiccups. And if you're seeing a lesion like this, this should raise your suspicion for NMO, and the aquaporin 4 antibody should be sent off. So here's the diagnostic criteria that I briefly mentioned that were published in 2015. And so if you have a patient who is aquaporin 4 positive, they only need one core clinical criteria. And I have the core clinical criteria listed here on the right. The most common four are optic neuritis, longitudinally extensive myelitis, area postrema syndrome, and acute brainstem syndrome, followed by narcolepsy, and then cerebral syndrome with NMOSD typical brain lesions. So if you have a patient who is aquaporin 4 negative, you need them to have two core clinical criteria that are met, with at least one of them being either optic neuritis, longitudinally extensive transverse myelitis, or area postrema syndrome. So the recovery from NMO attacks is, unfortunately, complete recovery is rare, and a lot of patients who have had the outcome is the majority of patients with transverse myelitis have partial or no recovery despite receiving treatment for an acute attack. And then very similarly is with optic neuritis, partial or no recovery in 68% of patients. So how have we, up until this point, how have we treated NMO attacks? So standard of care is methylprednisolone, 1,000 milligrams daily times 5 days. And then the thought has been that if they're not improving, then you give them plasma exchange. However, more data is supporting that the earlier you start plasma exchange, the better the outcome is for these patients. So I advocate for starting methylprednisolone and plasma exchange at the same time. So this study published in 2015 showed that if you treated a patient with if a patient received IV methylprednisolone and plasma exchange, 2/3 recovered back to baseline versus 1/3 if they received methylprednisolone alone. And this study, most recently, I believe it was published in the last 2 years, showed that it supports starting plasma exchange earlier. And it showed that when you initiated plasma exchange earlier, so that was, the earlier you initiated it, the better the outcome was. So the strongest predictor for long-term outcome after an NMO attack was when you started that plasma exchange. So this is this is a graph from that paper, or a table from that paper, and basically what they're showing is that plasma delay. So if you are starting the plasma exchange within the first, so this top line, starting the plasma exchange within 24 hours, the patients have a 50-50 chance of recovering back to baseline versus IV methylprednisolone alone. Now, moving on to preventative therapy for NMOSD. So prior to 2019, we mainly had observational studies and really looking at just different immunosuppressive medications just based on observation. And we were using azathioprine, rituximab, and mycophenolate. And then it was in June 2019 that we had our first FDA-approved medication for NMO, a seropositive NMO, and that is eculizumab. And eculizumab is a monoclonal antibody that interferes with the complement cascade. And it specifically targets C5. So this is a primary, this is a Kaplan-Meier curve from the New England Journal article for eculizumab, and this shows a 94% risk reduction of eculizumab for NMO attacks versus placebo, so pretty remarkable. In addition to eculizumab, two other therapies over the last year that followed were inebilizumab and cetralizumab. So inebilizumab targets CD19, whereas cetralizumab targets IL-6. And so for the sertolizumab, Sakura Sky and Sakura Star were the two studies. They included, this is different from the eculizumab where it included only seropositive patients. Sakura Sky included both seronegative and seropositive patients. And when you factor out the seropositive patients, there was a 79% risk reduction in relapses. And it was FDA approved in the last 6 months for seropositive NMO disease. It was not found to be effective or clinically, there was no clinically statistically significant difference for seronegative patients. So it's currently only approved for seropositive patients. And then moving forward with inebilizumab NMO-Momentum study, this basically showed similar comparable findings to sertolizumab. So there's a 77% risk reduction for relapses. This study also included seronegative and seropositive, and it was found that really it was only statistically significant for the seropositive population. So it is also now approved for FDA approval for seropositive NMO, but not for seronegative NMO. And this table was generated by one of my mentors, and he let me use it for the talk today. But I just like it because it just shows overall risk reduction. And the risk reduction for aquaporin 4 IgG was 94% for eculizumab, and then for sertolizumab between 74 to 79%, and then inebilizumab for 77%. So even though the risk reduction is much higher for eculizumab, it needs to be kept in mind that these are not a direct comparison. There was no head-to-head trial for these three that has been conducted as of yet. And one thing that's important is that the eculizumab, it is very effective, but it does require a patient to come to an infusion center every 2 weeks. And for some patients who live very far away, that is not an option. And so the inebilizumab is every 6 months, and the sertolizumab is every month. So those are more easily, it just seems that for some patients it might be easier to do versus the eculizumab. So in summary, for NMO spectrum disease, it carries a high risk of permanent disability and mortality if left untreated. And when sending the NMO antibody, you do want to make sure that you're sending the cell-based assay on serum to limit the chance of false positives that can happen if you send the ELISA. For NMO attacks, you want to initiate treatment as early as possible and strongly consider concurrent IV steroids and plasma exchange from the get-go versus IV steroids alone. And we now have 3 FDA-approved medications for seropositive NMO, eculizumab, that's targeted against complement C5, inebilizumab, that's targeted against CD19, sertolizumab, that is targeted against IL-6. So lots of options with different routes of administration, which is nice for patients to have some options to choose from. And then these are my references. Thank you.